All right, so the floor is open. Dr. Cicero has laid down the gauntlet here on the demand side.
Yes, very interesting presentation.
Thank you.
Could you tell us a little bit more about predicting these things in advance? What principles we might apply prospectively?
Yeah, I think, again, basically asking people, is there anything new on the horizon that you've heard anything about? It turns out to be the local drug community, and Lee Hoffer looks at this a lot. But if you look at the whole drug community, there's an internal dynamic that works there. There's a market created there. But most importantly, if you look at any website with this, these users are very friendly to their co-users because they realize the difficulties you're going to have. So within 48 hours of the ADF or OxyContin coming on board, there was a description on the internet of how to circumvent the abuse deterrence formula. And it was right. And it's very easy for people to do that. They say, don't waste your time with this dealer because he's selling bad product. Surprisingly, dealers that are selling heroin that's laced with fentanyl and are killing people, they have a lot of return users. And in fact, they get new ones coming in because the death is unfortunate, but it was a sign that the drug was really super good stuff. So you're seeking out a dealer who's got bad stuff that could kill you, but they'll titrate the dose and make it work.
I'm sorry if I go a little out of bounds here, but I was struck by information that we were given suggesting in some other societies, particularly in Germany, for example, that while prescribing is at a significant level,
Yeah.
they seem to have less prevalence of this addiction. I wonder if you could speculate as to why we seem to be more vulnerable.
Yeah, I think there's actually more attention to psychiatric disorders. I think without much question, though, the availability of opiates in this country is what we consume, 97% of the world's opiate products. The tradition of medicine and all has endorsed the use of painkillers. In India, in particular, China as well, but Germany and Europe throughout, they use a lot less opiates than we do, so the supply is certainly an issue there. There wasn't anything at all. Plus, they get heroin shipped in at a very inexpensive cost. The real problem they're having right now is heroin, but now I got a call from a reporter for Al Jazeera, I guess, from Switzerland, that their basic problem right now is acetylfentanyl. So that's, again, it's an illicit drug. It's being imported in. But heroin is still strong there because it's so readily accessible. They had needle parks and all the rest of it. They had a very friendly attitude toward heroin, and it's cheap. And so cheap and very little volume to be able to draw from a therapeutic pool, I think accounts for it. But that's not all. Something else is going on. Maybe it's the drug cultures are just totally different. We need to understand that a little bit more. We just put a grant in actually to look at the social context of use in China, India, United Kingdom, and the United States to see why are we using so much, especially for post-surgical procedures. We use a lot of opiates and other countries don't.
Thank you so much, Mark Schumacher, UCSF. I'm one of the members
Hi.
of the committee. In your word cloud, and I've seen it before, the word pain appears, but it's much smaller than the others. I was wondering if you could just comment on your own experience and the interplay between pain history and misuse of opioids.
43% of our population has either received a prescription from a doctor or they're currently under treatment for pain. And a lot of these individuals are stealing drugs and they're getting fake prescriptions because their pain is not being appropriately managed. And what you really raised is a good point that I want to stress. The big worry we have with all these programs that we're putting into place is what is going to happen to the actual patient that needs the medication. Are we driving physicians away from using opiates entirely? I think it's certainly true in St. Louis. A lot of physicians are saying, I'm not going to deal with it anymore. All it is on the news every night that some white high school athlete overdosed on opiates. And I don't want to deal with it. I don't know how to recognize an addict if he comes into my office. And then I've got to deal with all the after effects and get the publicity and the people monitoring my behavior. So it's a significant issue.
My name is Davy Treewall. I work with Academies, manufacturer of Vivitrol. I was wondering, you mentioned that you don't believe that methadone and buprenorphine are adequate treatment. Obviously, you got to go towards the demand for opioids as opposed to just treating. What do you have any opinions on antagonist treatment?
If I had to pick one, that would be it. Vivitrol, I think, is if you can block the effects entirely, so the person is not getting the high he expects. Or if you can implant, I think there's now 30-day implantations you can get involved in as well. I think that certainly is the preferable route to go. Again, it won't solve the problem with demand, but at least it will inoculate, especially for physicians who, other healthcare professionals that are really on a timeline. You've got to stop taking now or else. I think they need that extra motivation that would provide.
Thank you.
Lee Hoffer from Case Western Reserve University and a member of the committee. And Ted, I was wondering if you could talk a little bit about this notion of stigma for heroin and how that was sort of linked in this process to the drug itself, and sort of what outcomes have you seen in your data? Because I think this is sort of an interesting dynamic that sort of seems to. So now we have a heroin epidemic that's now no longer connected here.
Yeah, what's scary about that is that, yeah, we have a heroin epidemic now, but what younger people who used to think that I didn't take heroin because it was a dirty, junky sort of thing to do, they're now seeing their friends who were once on prescription opioids using heroin that is apparently accessible very easily now at parties and that sort of thing. So we see over the last 18 months a big increase in the number of people who took heroin as their first opiate because there was no stigma. It was shrinking and they saw friends using it. It was readily available and they just went to the thing. It was inexpensive and available. It's a scary development. Once that population, we're up to about 30% now of our population last quarter indicated they had used heroin was their very first drug to attempt. We never saw that 5 years ago.
The prescription monitoring programs are state-run programs, and there's a tremendous amount of variability in these programs. Do you have any opinions on the, what makes a good one or the effect in this process?
Speed. Most of the physicians that we talk to about PMP say, I don't have the time, I'm on a busy practice. And this came up earlier today too, most of these physicians are GPs. They actually give out most of the opiates, or dentists in that category as well. What was your question again? I lost it.
Oh, if you had an opinion on, they're so variable on what makes a good prescription monitoring.
Speed. The one we hear most often is physicians can't take the time to stop, go to a computer, log in. Even if it only takes a minute or two, they're less likely to want to use that. There's also some fear, and Missouri is the only state in the union that doesn't have one, because the Republican conservative believes that this is just a further attempt by the government to get information on people so they don't prescribe it. But a lot of physicians do worry that if they go on this website too often, somebody's tracking their behavior, and they could actually be confused in some way as sort of a pill dealer. So I do think they have worked to some extent. They're useful for the GP who's very conscientious. I'm a little worried that it's off-putting to people prescribing opiates. And that's the last thing we want to do, is deprive patients who legitimately need these prescriptions with the drug because somebody's afraid of being watched.
Beyond the studies of abuse liability, when and how often and perhaps in what phases could a company manufacturer assess demand for their drug, especially if it were in the diverted scene?
Yeah, it's very difficult. You'd have to actually go. There are some diversion programs now that look at source of drugs. There's something called Street RX out there where you can get relative cost of drugs in various cities. You can sort of look at demand in that respect, but it really requires studies that I don't know that the FDA is necessarily the right agency to actually be carrying them out. I think the National Institute on Drug Abuse should be far more interested in this problem because, again, it's driving the demand. NIDA should be, and Nora's not here, but she knows my view on this. We got to be spending, and it isn't just the company's responsibility to look at these problems. This is a national problem, and we need all aspects of government working hand in hand to get it. I don't think the FDA is well equipped or well resourced enough to do these kinds of studies because it's a very broad question. I think you'd have to sit down, and that's what I'd love to see more committees working on, sit down and say, what should we attack first? What should we look at? And come up with plans. And I think, God forbid, the drug companies might want to work together on this because these are very costly studies and they need to be paid for by someone. If, in fact, all the companies could trust one another well enough to have an independent committee that could run some of these long-term trials. It's just like the whole use of opiates for chronic pain. It's amazing to me that after all these years, no one's done the definitive study to see what % of people who are given an opiate initially, even from a dentist office, what percent of those people actually ultimately developed a problem with it? My data suggests it's very high, but again, I'm looking at a population that's select. They're in treatment, they got in trouble already, but I don't know how many people got an opiate that subsequently developed a problem, because there's no really good studies that looks at that. What is a threshold level of exposure to opiates before you got a problem?
Hi, Paul Jarris, Marshall Times. I'm going to re-ask the questions.
Okay.
Excuse me? Oh, that somebody asked before. For evaluating pharmaceuticals for MAT, are there potential outcomes short of total abstinence that might indicate a beneficial medication?
Yeah, I mean, I think if you can reduce to some extent the amount of use on a daily or weekly or daily basis, that certainly is an optimal outcome. There's a lot of argument about whether you can really be a partial, once you've been an addict, whether you can be a partial user. Can an alcoholic ever go back to moderate drinking? Probably a very small percentage, but some seem to do it. But I don't really have a good answer for your questions about how often that would actually occur. I don't really know that there are too many recreational users, and I hear that phrase very often. I don't know what it means. I don't know what a recreational user is. I mean, is he using it once a week, twice a week, for parties and things of that sort? What's scary, I'll have one last comment. We did a study at Washington University with students. It's a very difficult school to get into. These are fairly smart kids. All of them were using stimulants to study. This is a study drug, so they would use those. But on the weekend, they switched to party drugs. There's a lot of exchange of drugs because they look on the internet and see what ADHD is, and they can go in and simulate it. And apparently, there are a lot of doctors that they can go to, and they'll get these study drugs. But then they trade on the weekend for Xanax or opiates because those are now party drugs. So you make a shift from study drugs to party drugs. And it's scary what kids are doing. So.
Okay, thank you very much.